Hi everyone, my name is Tashelle and welcome back to the journey. So as you can see in the first video, we talked about diabetes part 1. Well, today we're going to go ahead and talk about diabetes part 2. And with that said, we're pretty much going to talk about the treatment and medication that is used to treat type 1 and type 2 diabetes. Okay? So we're just going to get right on into it. The number one treatment for diabetes is diet and exercise. I cannot stress that enough. You know, I always say the best treatment is no treatment, okay? And what I mean by that is pretty much if you can do the things that you can normally do as far as a regular diet, a good diet, and good exercise, right? That can prevent a lot of diseases from occurring, or it can help control a lot of diseases that you are experiencing right now. So the number one treatment for a diabetic is going to be diet and exercise, at least when it comes to a type 2 diabetic. Type 1, remember as we talked about in part 1, a type 1 diabetic, there is a destruction of the beta cells. So now we have something physically in the body that is not working. So we need insulin to replace what wasn't able to be produced from the pancreas. So when it comes to type 1, it's a different treatment, and the treatment is strictly insulin. It's just only insulin, okay? But type 2, you have a little bit more leeway. You can do a little bit more with type 2. You have oral medications, you have insulin, which ultimately that's when it progresses to a more progressive stage. And then you can also, number one treatment, diet and exercise. So for diet, okay, we're gonna go by the American Diabetic Association, okay? And from there, you can see on my plate, they have an illustration showing exactly what a diabetic diet consists of. And one of the main things is going to be less carbs. Why? Because carbs are sugar. And what does a diabetic have problems with? Sugar. So if we cut out less sugar, we have less problems. So now, we're going to go ahead and talk about exercise. Now, exercise, you want to do aerobic exercise. Okay, and the type of aerobic exercise that you can do are walking, jogging, and biking. Alright, those are some good exercise that you can do, and your duration, you should do it about 30 minutes 5 times a week. Okay, 30 minutes 5 times a week. One major thing I want to discuss about exercise is pretty much be careful when you're going to exercise. Make sure that you are eating before you exercise, because exercise is going to help bring your blood glucose down. So if you have a lack of food and you're exercising and all of a sudden your blood sugar drops, now we have another situation, another problem, okay? So one major thing that you have to remember is if you're going to exercise, make sure you eat a meal, okay? And monitor exactly how much exercise you're doing. Don't overdo it, don't overwork yourself, listen to your body. That's a major thing, because if you feel dizzy, confused, remember the different signs of hypoglycemic? If you feel any of those symptoms, you need to stop, relax, get something to eat. And it can be an apple, it can be a banana, it can be, a sandwich or so, but you have to eat something. And you don't want to take this in conjoined with insulin, because of course it's just going to make the effect even worse. And you just want to make sure that you're doing it all in moderation. Okay, same thing with the food, all in moderation. Okay, so now we're going to talk about what if the patient is far gone diet and exercise. The blood glucose cannot be controlled with diet and exercise. Well, now here's the help of diabetic medication. And these are all the listings of all of the different types of diabetic medication that a patient can have. And again, you would discern which type will work with which patient based on the consequence or the effect that is going on with that person's body. Okay. So now we're going to talk about insulin is one of them. Sulfonylureas is another one. Bagonines, okay, which is also known as metformin or glucophage. All right. This one I'm not even going to try. But the name is called TZDs or glitazones, which I love to call glitazones, okay? Because these words can sometimes be a tongue twister. You have alpha glucosidase inhibitors, which I call carb blockers. And then you have dipeptidase 4, which is also known as DPP4, which are incretins. Alright, so now we're going to discontinue. You also have the incretin Minitec, which is pretty much GLP-1, which is another type of incretin. Okay, and then you have the gliadinines and then glucose elevating agents. Alright, so now I'm going to go through the main important ones that you will see on your testing, the ones that you will see the patients in the hospital prescribe, the very most common ones that you would see. Alright, now we're going to talk about drugs that increase the blood glucose levels. Okay, so now we have corticosteroids, thyroid hormones, epinephrine, Lasix, which is a loop diuretic. And then you have thiazide diuretics, which is also another diuretic, but it depends on where it's working. So where it's working is the distal convoluted tubules, okay? And then you have beta blockers, estrogen therapy, and digoxin. All of these medications contribute to an increase in blood glucose. Now, we have the drugs that decrease the blood glucose levels, which we have alcohol, salicylates, which is aspirin, and this is the abbreviation for aspirin, so if you see this, that's exactly what that is. MAOI, which these are monoamines oxidase inhibitors. These are antidepressant medications. So these are the patients that you would be on psych or very suicidal or very depressed. These are the medication that you would see them on. Okay. Then you have anabolic steroids, which are pretty much male sex hormones. And then you have guanethine, which is a blood pressure medication, okay? Please forgive me. I know when it comes to pharmacology, the words and pronunciation is very difficult. At least for me, I know it is. So I'm just giving you a warning ahead of time. If you see me pronounce something that is completely wrong, do not laugh at me, all right? But I will do my best to pronounce it the right way. And last but not least, herbal medications that decrease the blood glucose level, which we only have 3 here: garlic, bilberry, and ginseng. Now you're probably saying, okay, what's the big deal? Why is she going over these medications that increase, that decrease, and herbal medications? Why? Because you're going to get those big questions of what drug-to-drug interaction mixes with the diabetic oral medication that will either enhance the drug, decrease the drug, or alter the drug. So a lot of times if a patient is taking garlic or bilberry or ginseng and they're on these oral medication, well, this helps to decrease. So I have an extreme effect because I'm already taking a medication that's going to decrease my blood glucose level, and then I'm taking these herbal medication that are also going to decrease my blood glucose level. So then next thing you know, I'm going to bottom out. So that's why I went over these slides to just let you know these are going to be the drug-to-drug interaction. So if you can kind of get in your head an idea, okay, corticosteroids, you know, alcohol, you know, salicylates, which is pretty much aspirin, all these different medication in your head, you can kind of get an idea, okay, these are going to interact and either cause a benefit or cause a consequence, okay, with these medications. So now we're going to talk about the anti-glycemic pharmacodynamics. Now the pharmacodynamics is pretty much how the drug is working, alright? So these are the different ways how the drugs are working, and I'm going to go over them, and then I'm going to show you in each drug how each drug is either doing either one of these things. Now there's some drugs that are going to do multiple things on this list. There's some drugs that are only going to be specific to one thing or have a target organ that they are able to work, and that's how they are metabolized, and that's how they give their benefit. Okay. So first things first, they're going to decrease the absorption of glucose in the GI tract, which is very important because as you're eating food and you're eating your carbs, right, your body's able to absorb all of those things. So what these medications are going to do is going to decrease the amount of glucose that you're absorbing in the GI tract. The next thing that's going to happen is there's going to be a decreased production and secretion of glucose in the liver. Now remember that picture, because that picture is really what's going to help us to understand how these drugs are working and where they're working and how they're working. So remember that liver store that glycogen, right? And once that glycogen is stored, glucagon then stimulates the liver. Remember the picture? Stimulates the liver. The liver then breaks down that glycogen into glucose, and then it's released into the bloodstream, which increases the blood glucose level. So one thing that the medication is going to do is decrease the production of glucose from the liver, okay? Another thing that's going to happen is there's going to be an increase in beta cell secretion of insulin. So remember we had the two picture, they had the pancreas at the top, pancreas at the bottom. Remember, the beta cells is what's going to give off the insulin, and the insulin is then going to go into the bloodstream and grab all of those sugars and put it into the cell. So it's going to increase that effect, which is a good thing because remember you have all that sugar into the bloodstream now. So if you can increase the effect of the beta cell secretion of insulin, then you're able to decrease the blood glucose level. And then also you're going to increase the effectiveness of insulin at the receptor sites. Remember what I was saying, sometimes it's not the fact that it's the insulin secretion, but the fact of the insulin resistance. When it goes to that receptor site, right, it's not able to latch on to grab that cell grab that blood glucose into the cell. So what these medications are going to do is pretty much increase the effectiveness of the insulin receptor sites. So insulin resistance is now going to be increased sensitivity. So now when the insulin is getting ready to bring the glucose in, it increases and locks into it, open that door so that way the glucose can get inside the cell. Okay? So I'm going to explain now the different drugs that are doing different things in the body. So first up, we have sulfonylureas, and as you can see here, sulfonylureas is going to end in typically MIDE or AIDES. So I have a few examples here that you can see they end in AIDES, okay? Now, with this drug, you have first generation and second generation. Now, of course, you may say, okay, what is that? Pretty much, as you can see, as technology and research is enhancing, you can make better drugs. So that's pretty much what happened here. Years ago, they had just only the first generation drugs, and this was the only thing that they were able to use for the treatment of diabetes. Now, with this drug, it increased the risk of cardiac disease. So then now they made a second generation, which are, I guess, the new and improved, okay, class of medication that they use. So very rarely would you see them use the first generation. Now they just kind of strictly use the second generation. But again, everybody works different, and some people may react better to first generation than second generation. So it's not odd to kind of see certain medications being used for certain patients, okay? But most commonly now that's being used is second generation, all right? And second generation is a longer duration, which means that the medication lasts a lot longer into the system, which is able to continue the benefit of the medication. And then it's also now excreted into the urine or the bile. And the bile is pretty much an area where it's located in the gallbladder, all right, and it goes through the bile ducts, and eventually it's excreted in the urine. So now we have the action of sulfonylureas, right? How are they working? What are they doing? So they're going to stimulate the beta cells, okay? So get your picture in your mind. They're stimulating the beta cells to secrete insulin, all right? So they're knocking on the door of the pancreas and saying, hey, beta cells, wake up, right? It's time to make insulin. So they stimulate the beta cells to make insulin, right? And remember, don't get this confused with type 1. Remember, type 1, there is no beta cell. So these medications will not be for type 1. These are strictly only for type 2 diabetics, okay? So everything that I've gone over so far is for type 2 diabetics because they do produce some type of insulin. It may not be the most effective type of insulin, but they do secrete some type of insulin. And the body can say, hey, if you give me something to work with, I can help you, right? But if you give me absolutely nothing, then I cannot help you. So this is why you will see these medications will not work for a type 1 diabetic. So again, remember that because those can be test questions where you see what are some medications that you will see a type 1 diabetic use, and you will see oral diabetic medication. That is a no, because these medications are working in the sites where it kind of help give that extra boost to insulin. How can I give that extra boost to insulin when your body doesn't make any insulin? Okay, so just remember that, because those are some of the test questions that you may see that they use to trick you. All right, so they're going to stimulate insulin to be produced in the beta cells, right? They're also going to improve the binding sites from the insulin to the insulin receptor, all right? So they're increasing the sensitivity, right? And then they're going to increase the number of insulin receptors. So let's say, right, I may have the amount of insulin that I need, but the key to open the door, right? So because I have the locks, but I don't have enough keys, right? We're gonna have a problem. So what it does is allow more keys to access those locks, if you can kind of think of it in that sense, okay? So it's going to increase the number of insulin receptors, all right? So just think about it, I have a whole bunch of locks and a little bit of keys. This medication comes into the body, creates more keys to open up those locks, so now those cells can go ahead and get the glucose, okay? Now, pharmacokinetics, all right? You may think, what is pharmacokinetics, okay? It is just a fancy word to pretty much tell you how the medication is working. And if you can break it down, pharmaco is medication, kinetics is movement, how and work, right? So how the medication is working. So the medication is working by, it's being absorbed in the GI tract. So the minute you eat a meal or something like that, and you digest this, you take it with this medication, it is working in the GI tract, okay? And it is quickly absorbed into the GI tract, okay? And then contraindications. What is contraindication? Contra means against. Indications means when am I going to use it? So contraindicate is when am I not going to use this medication, okay? So I'm not going to use this medication if the patient says that I have allergies to sulfur drugs. Why? Because in the name of the drug, it's called sulfonylurea, so that means it has some type of sulfur. And if they're allergic to that, you're going to get a reaction, whether it's rashes, closing up of the throat, whatever signs and symptoms that the patient may experience or tell you that they're allergic to. So one of the biggest contraindication is sulfur, an allergy to sulfur. So the side effects of sulfonylureas is pretty much hypoglycemia, and that's one given side effects that we can all kind of remember. If you're going to have a medication that function is to decrease the glucose level, one of the obvious side effects is going to be it can drop it too low where you now have hypoglycemia, okay? So with each of the medication, you can think of hypoglycemia, okay? So another thing is GI disturbances, which you're going to see a lot with other medication as well, GI disturbances. And what I mean by GI disturbances is pretty much diarrhea, flatulence, which is pretty much passing gas, okay? And then you have abdominal pain, okay? Also, if you are allergic to the sulfonylureas, you will start to see the allergic skin reaction, where you may see the hives, or they may have redness, or they may be complaining of itchiness, or they may have rashes, okay? So those are another thing that you want to make sure that you're paying attention to in your patient, because sometimes they may never have any history of any allergic reaction, and then they're taking this medication. You want to be able to observe those signs and symptoms of, hey, I think you're allergic, or you are allergic, okay? And then weight gain is a side effect that can happen to some people. So our next class of medication is the non-sulfonylureas. And within the non-sulfonylureas, we have bagonines. And bagonines is pretty much, there's only one drug in that class, which is like, thank God, right? Metformin. Now, metformin is the generic name. Glucophage is the trade name. And that's another thing you're going to get into, is when you start to see medication, they have more than one name. And with that, I always recommend try to learn the generic name. Why? Because on NCLEX, every time they test you, it's only going to be the generic name. So why waste your time learning the trade name, then you see the generic name and you have no idea. You know the drug, but because you never studied or paid attention to the generic name, you're now not able to answer the question, okay? When clearly you do know the drug, you just never been familiar with that name. So metformin is the generic name, glucophage is the trade name. And what I mean by trade name is pretty much businesses or corporations that is like the name brand of the drug, okay? So you have Tylenol. Tylenol is the name brand. That's what everyone knows. That's the big corporation, the big market company that we all see on the medication brand, right? Tylenol. But really and truly, Tylenol is acetaminophen. And you may say, what? Tylenol is acetaminophen. That is the generic name. But we don't really hear it as that. We just hear it Tylenol because that is the name brand. So that is something that you will see. Trade name versus generic name. I always say generic name trumps the trade name because NCLEX is going to only test you on that. So now back to what Metformin is going to do. So Metformin, the action of what Metformin is going to do, it actually has several. But I just want you to kind of get this picture going in your head and just know that the main function of Metformin is going to attack the liver. The liver, the liver, the liver. Okay, if you don't remember anything else, no, Metformin is going to mainly deal with the liver. Okay, at least most of the test question, the answer is going to be liver. Okay, so it's going to decrease the hepatic glucose formation. Now remember, like I told you, the glucose is going to be stored in the liver. The liver is going to then change that into glycogen, right? And then it's going to store it there until it's ready to then be released as glucose to go into the bloodstream to help bring the blood levels up. So with this decrease in the hepatic glucose formation, that formation does not occur, right? So that helps to decrease the blood glucose. All right. Also, it increases the peripheral glucose uptake. Now, you may say, what does that mean? Peripheral glucose uptake. Remember, this is in your bloodstreams, right? And who else needs these things in your bloodstreams? Think about your extremities, right? All this, right? I have blood flowing through my arms, my core, and then my legs, right? So my extremities that are here, these are my peripherals. What's in my peripherals? Right? My muscle cells, okay? So think of those type of things, your adipose tissue, your muscle cells, these are the things that are in the peripheral glucose uptake. So it helps increase that. So all of the sugars that is resting in your bloodstreams, right, there's an increase of an uptake in that. Another thing, there's a decrease in intestinal glucose absorption, which is a good thing. So that means that when you're eating food, right, your body's not able to absorb all of the glucose, which is a good thing because for diabetic, you don't need as much glucose because your body's retaining too much as it is and is not being able to use it effectively. And then you're going to have a decrease in glucagon effect, which we talked about the glucagon effect. Try to remember that picture, right? And you have the alpha cells now secreting the glucagon. And what does the glucagon does? It knocks on the liver's door to say, hey, bring out that glucose, which you do not want. So it breaks that effect. And the reason why it's going to break that effect because you already have enough sugar in the bloodstream. So you don't want to add more to that. You want to decrease that amount. So this is how the Glucagon Metformin is working in the body. But remember, if you don't remember anything else, because it's a lot that it's working and it's targeting, the liver. Remember the liver, okay? It's going to work in the liver. So one of the things that you're going to watch out for, right? I'm jumping ahead, but one of the things you're going to watch out for, if it's working in the liver, what does that mean? You got to have a strong liver, right? So now, one thing with metformin is that it is the only drug that is approved to use in children who have type 2 diabetes, okay? So that's an easy given thing. You don't have to worry about all the other medication. If they're asking you a question about children and what medication is going to be prescribed, you already know metformin, because metformin is the only one that can be prescribed for a type 2 diabetic in a child, okay? Now you're going to have my signs, not signs and symptoms, my side effects, okay, or adverse effects. So one of the major thing which I highlighted in red, so you can really target and pay attention to, is there's going to be an increased risk of lactic acidosis. Okay, increased risk of lactic acidosis. So with this medication, you want to be careful and be cautious with a patient who may be showing signs and symptoms of lactic acidosis. Okay, and then you can also experience congestive heart failure. Okay, so these medications are really going to take a toll on you once you've been using it continually time and time again, All right, and then you're also may experience GI disturbances, which I already told you before, is diarrhea, abdominal pain, and flatulence, which is gas, okay, because it is also working in the intestines, okay. And one thing that it's doing is when that glucose is not being absorbed in the intestines, it has to go out somewhere. Where does it go? It goes out the rest of the GI tract, right? So you're going to eventually poop it out. So when you're doing that, all that sugar is going into the colon. What's in the colon? Bacteria. Bacteria loves glucose. It feeds off of the glucose. So when they're eating that glucose, right, eventually the bacteria is going to, excrete their waste, and that waste is gas. All right, so that's one thing that you can kind of remember how flatulence is going to occur, because those extra sugars is going into the colon. The bacteria is eating that sugar. Once it becomes a waste product, they excrete it as gas, which causes you to then have gas. So now we have special considerations that we need to pay attention to when it comes to metformin. So with metformin, you want to hold in 48 hours if the patient has to go for a specific procedure. And that procedure is pretty much anything that requires a dye or dye contrast or iodine contrast. Because what metformin is going to do is going to bind to the dye. So most of the time the different procedures that are going to require dyes, or at least the dyes that are going to mix with metformin, is either CT scans or cath lab. And what cath lab is pretty much, patient has any cardiac issues or a heart attack or anything like that, they go up into the right groin, or they may go into the radial artery, and they would pretty much fish a wire into the heart. And as they're doing that, they need to see the vessels, so they use this dye that lights up in the body where the vessels are, so that way it can kind of maneuver its way. Now when that dye is into the body, it is a very sticky substance. When you touch it, it is very sticky. And just think about something as sticky as that going into your vessels. Now remember, as we were talking about before, who has to filter the blood? The kidneys. So the kidneys now have to work overtime to get all that sticky substance that is in the blood, which is why when you're going to even do this procedure, you want to make sure that you check 2 levels. Remember those 2 levels that we talked about in part 1? Bun and creatinine. Okay, so you want to make sure before you even take a patient to this procedure, check their bun and creatinine. And you already know with diabetics, they are going to have, or it's more likely for them to have an elevated bun and creatinine. Why? Because the kidney is already working overtime, because they have to filter out the sugar. So once the bun and creatinine levels are at an appropriate level, and the doctor gives the okay for the patient to go and do this procedure, you want to make sure this medication is held for 48 hours. Why 48 hours? Because that is when the body is able to flush all of that medication out and pretty much put you in a safe place that when this dye does come in, it doesn't stick to the dye. Now you may say, okay, but it's going to flush out through the kidney. Now remember, if this dye is staying in your body, if the metformin is staying in your body for 48 hours and it binds to this dye is going to stay in your body for at least 48 hours. So it prolongs the filtering process when it's combined together, because it attaches itself to the metformin and it circulates into your bloodstream constantly until eventually it is finally getting rid of, which by that time it would have already caused so much damage to the kidney. All right, so that's one special consideration that you want to watch out for. Now, we all know we live in this world and there are emergencies, right? And let's say the patient has a heart attack and he's in emergency surgery right away, right? And the patient ends up being a diabetic. One thing that you can use as an antidote is Mucomyst. Okay, you may say, Mucomyst, what is Mucomyst? Yes, Mucomyst is the same medication that you use when you are so congested and you want to get rid of all this mucus. What does it do? It decreases the amount of viscosity of the mucus, which is why some people use it as a cough medicine, or not really cough medicine, but more of a mucus medication to kind of clear out your sinuses and get all those things out. So I don't know if you guys seen those commercial with the Mucomyst, commercial with a little snout, a little burger guy. you can kind of think of something like that, okay, when it comes to mucomist. And mucomist is the antidote for metformin when it binds to the dye. So in a case of emergency situation and we don't have a 48-hour window to kind of wait and we need to do something right away, you're going to use mucomist with the dye so that way it doesn't bind, okay? And another thing with mucomist, which I'll also say at another time, is the antidote for any hepatic toxicity. And you may say, what is hepatic toxicity? Hepatic is the liver, toxicity is damage, right? So any damage to the liver, right? An antidote is mucomist. So what is one medication that causes damage to the liver? It's very, very common, Tylenol. Tylenol causes a lot of damage to the liver in very high doses. So if a person was to ever overdose on Tylenol, the antidote for that is mucomist. So you have mucomist as two antidotes for metformin and Tylenol, all right? So I know I jumped ahead, but I know when your professor asks you those questions, you will sound very, very smart because she'll be like, whoa, where did you get that from? Okay, so you're already one step ahead of the game. So mucomist is the antidote if it binds to, if metformin binds to the dye. All right, so the next drug that we have, okay, is meglitinides, okay, which is also known as glinides because they end in glinide. So you have regular glinide and nate-leglide. So these medication is pretty much similar to the mechanism of action of the sulfonylureas. So this is the newest class of the non-sulfonylureas. And remember we have bagadines in there as one of the non-sulfonylureas, and this is the newest class that they've had. And within this drug, this medication here, Steroids, is the newest member. All right, Steroids is pretty much the trade name. Remember, in parentheses is the trade name. All right, and how this is working, it resembles, like I said before, the sulfonylureas. And remember, if you guys remember from earlier, I stated that sulfonylureas increase the release of insulin from the beta cells. So it's increasing the release of insulin from the beta cells, and this is how this medication is working, which can be a good alternative for those who are allergic to sulfur because this is non-sulfur. So this may be a good medication for someone who has allergies to those medications, but know that, hey, this medication really does work. And this medication can also be used in combination with metformin, and then you will see a lot of medication are in combination with another, which is called your fixed or mixed combination of oral diabetic medications, okay? And a lot of the mixing you will see is metformin. Metformin will be with just about every other medication in the mixing process. So now we're going to talk about alpha glucosidase inhibitors, which I like to call carb blockers, okay? And the reason why I call them carb blockers because very obvious, one of the medications is called acarbose. A means against, carb is carbs, so against carbs. So these are your carb blockers. All right, so under red is going to be your generic. On the side is your trade name. All right, so if you see Precoce or Glycosate, it's the same thing. Now I put both because sometimes the professors may use the trade name and generic name, or she may just only use the trade name. Depends on what the professor wants. I know when I was in nursing school, the professors put both, which was a good thing because, you know, I mainly studied the generic. But sometimes they may put both, or sometimes some professors may forget and only just put the trade name. So I just put both there so you can see. All right? So you have the action, all right? And what the action is going to decrease the absorption of glucose in the intestines, okay? So that is the pharmacokinetics. That's what's going on. That's how the drug is working. It is going to decrease the absorption of glucose in the intestines. How is it doing that? This is how it's doing it, okay? So remember, when you're eating food, right, and you're eating carbs, most of the time we're not really eating simple sugars. And simple sugars is just pretty much sugars that has broken it down in its simplest form, okay? Like glucose, it's the simplest form, right? But most of the time when we're eating carbs, we're eating bread, we're eating pasta, whole wheat, grain, and things like that. And those are, how can I say, compounded sugars. which they're pretty much glucose attached to glucose, attached to glucose, attached to glucose. And when you have many glucose attached to each other, they're called polysaccharides. I don't know if you guys remember that from chemistry, all right? Poly means many, saccharide is sugar, so many sugars, right? Once that polysaccharide is digested into your body is like, well, I can't use this. I need to break it down into a form that I can use, which is glucose, which is a simple sugar. So the body then further breaks it down to a disaccharide. And remember, disaccharide means two. So now we have a chain of two sugars. But the body says, I still can't use that. I need it to be broken down even more. So then the body finally breaks it down to a monosaccharide, which is finally what you get, glucose. So now, how does that happen, right? In order for something to be broken down, an enzyme always has to take place. So an enzyme is what is going to break down that polysaccharide to a disaccharide to a monosaccharide, right? So how this medication is working, bear with me, you guys. I don't want to lose you. I know chemistry is like, but just bear with me, okay? How this medication is working is it blocks that enzyme from breaking it any further, okay? So it blocks the enzyme from breaking it down to a monosaccharide. So it may stop at a polysaccharide, it may stop at a disaccharide, trisaccharide, right? But it doesn't get broken down to a point where it's a monosaccharide, because once it's broken down to a monosaccharide, the body then absorbs it, right? And you don't want that because this is a diabetic patient and they already have an increase of blood glucose, so you want to maintain it. So what you're going to do is block the enzyme from breaking it down. So now that it can't break it down, the sugar has to go somewhere. So it goes through the intestines to the colon, right? And then you eventually excrete it out. And when you do that, right, some of the side effects that you can have are going to be, you guys know, GI disturbances, right? So you have your GI disturbances. Why? Because all of that sugar is going to go into the colon. That bacteria is going to feed on those sugars. And once they feed on those sugars, right, you are going to have the flatulence, right? And because it's working in that particular area, you may have an upset stomach at times, right? You may have abdominal pain. You may have diarrhea, okay? Biggest thing. So with this medication, all right, this is how it's working. And now you can kind of see why those side effects are occurring because of where it's working in the body, in the GI tract. So, like I said before, your side effects is going to be your GI disturbances. Okay, now you can kind of see why. The next drug, okay, I'm not going to try, you guys, okay? All right, maybe just once, all right, but don't laugh at me. Thiazolidinones, okay? But I refer to them as glitazones, all right? You can also refer them as TZDs, okay? You will see a lot of people call them TZDs, but I call them glitazones. Why? Because if I remember glitazones, I know anytime I see a medication that has glitazones in it, it's part of that medication, of that class of medication. And one thing I love about this medication is that every single drug in this class is glitazones, 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 okay? It doesn't change. So as long as you remember glitazones, you are in your safe place of knowing what this medication is going to do, all right? So this is the generic name, and then I have here, those are the trade names, all right? Now, one thing you need to know is that this medication is not used for people who are under the age of 18, okay? So I don't know if that may be a test question, or they may say, you know, a patient comes in who is 17 years old and they're trying to figure out which medication is not going to be the one to be administered or something like that, you know, and just in case they do have that question, you know, glitazones is not for anyone under the age of 18. All right? Another thing to know about the glitazones, all right, is a fasting blood glucose is required 12 weeks after the use of the medication before you can increase the dose. And that's something to know. So before you just increase the dose on your own, you want to make sure that you're doing a fasting blood glucose level. All right, so then they can kind of monitor where your blood sugar is and then see how much medication you need based on the results they get. So to continue on the glitazones, all right, how is the glitazones working? So how it's working is it's going to increase insulin sensitivity. All right, I'm going to say this again. It's going to increase insulin sensitivity. One more time. It's going to increase insulin sensitivity. All right. How is it doing that? It's increasing the glucose uptake in the skeletal muscles. Pretty much, you can use that same word as the peripherals. All right. Increase glucose uptake in the peripherals. All right. And I'm stressing this so much because when I was in nursing school, this was the drug that gave me the biggest problem. Why? Because if you notice, when I stated earlier, metformin works in the peripherals as well, right? And when I had a test question, and I remember, I think the question asked which medication works in the peripherals, right? And of course, the professor had both answers, glitazones and metformin. And I was like, well, metformin is the more popular drug. I guess that's the more common drugs. I chose metformin, and got it wrong. It was glitazones. So I'm stressing it because I'm telling you, this just may be a test question that you're going to get. And as you can see earlier, like I told you, metformin works mainly where? In the liver, the liver, the liver. So if you have a test question and they say which medication works in the liver and metformin is a choice, trust me, 10 times out of 10, metformin is going to be the answer. And when they have a test question that tells you which medication deals with increased insulin sensitivity or increased peripheral uptake, right? 10 times out of 10, I'm telling you, it's going to be glitazones. Glitazones, 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 all right? So I'm telling you that because I got that question wrong every time, and she had it on the test and she had it on the final, midterm actually, and same thing, all right? So if you can remember that story, if that helps you, all right, definitely know it is in the peripherals that this medication works mostly on, all right? Now, you may say to yourself, how is it doing that, right? Because it's decreasing the insulin resistance. Remember that resistance that I was telling you, right? You want to have that key and that lock to interchange to open up that cell so that way the glucose can come in, right? How is that happening, right? It decreases the insulin resistance by enhancing the sensitivity of the insulin at the insulin receptor sites. So it increases the sensitivity, right, of that receptor site, so that way they can attach, right? And once it attaches, what happens is that blood glucose now is able to go inside the cell, okay? Big thing, all right? So all the peripherals, muscle, skeletal muscles, right? All that sugar that's in there, right, is going to increase the sensitivity. Glucose is going to then go inside the cell because now it is open and free for the glucose to go in. Now you may wonder, for those of you guys who needs to know how that is working, okay? Just if you want to know, you don't really need to know because I don't think they will test you on that type of level. This is more as far as on a doctorate to know the patho of how this medication is working. But for those of you guys who need to understand that, how this medication is happening is because it binds the PPAR, which is called PAR-Y, right? It binds the PAR-Y, and what happens is it increases the GLUT4, and when it increases the GLUT4, it increases the glucose into the cell. So that's what's happening, okay? So it binds the PAR-Y. So once that PAR-Y is bound, it increases the GLUT4, which GLUT4 increases the glucose into the cell. All right. So for those who it just went right over your head, just let it go right over the head. All right. But for those of you guys who, oh man, I need to know, now you know. So if it sticks better for you, great. Now, side effects. All right, the main side effects: liver failure. All right, liver failure and cardiac problems is the main thing. So with this, all right, most of the time they're gonna do a liver function test, and if your liver enzyme is elevated 2.5 times greater or higher than what it originally was, okay, they're going to DC this medication because eventually, automatically, it's going to cause liver failure. All right, and you don't want that to happen. So this is what glitazones is going to do and its mechanism of action. So these next couple of slides that I'm going to do, they're not the most common type of test questions, okay? So like I said, you know, I always like to prioritize my studying. So definitely, I always like to talk about the main things first. And then if you have extra time, then you can go over some of the other things, just in case you may get 1 or 2 questions on it, okay? But these medications are not really test questions, okay, or they don't really formulate test questions. The ones that I went over before, those are your more popular test questions that you're going to get when you're studying, when you're going to take your test for NCLEX. Those are the ones that are more common, okay? But I am going to go over them just in case those of you guys, you know, are a little bit anal like me and just want to just have a basis and just cover some of the material, so that way you can kind of know exactly how some of these medications are working, okay? But I'm just letting you know the ones that we did earlier are the ones to more focus on, all right? So I have my DPP-4 inhibitors, all right, which are called glucagon. And I say that because each of the medication, all right, they ends in glucagon. So here is the generic drug, and here are the trade names of the drug, okay? Now, how this medication is working. So the action of this medication is, it is going to increase and prolong the action of incretin. So you may say, okay, what is that, right? So incretin is pretty much going to stimulate the release of insulin and decrease the glucagon levels, right? So incretin is the thing that you can call that kind of makes homeostasis within the body when it comes to glucose levels, okay? And it stimulates the release of insulin when insulin is needed because there's too much blood glucose in the blood, right? And then by it doing that, it decreases the glucose levels, okay? So the glucagon levels, because everyone knows what this glucagon does, is going to increase the blood glucose by stimulating the liver to release those extra glucose. So that's how it's keeping a balance. All right, so that is the mechanism of incretin, and what this medication is doing is just pretty much mimicking what the body is already naturally doing, is mimicking incretin, and it is increasing and prolonging the action of it. Okay, does that make sense to everyone? It is going to just mimic what the body is already doing, okay, which is increasing and prolonging the action of incretin. So this dose is going to be a daily dose, okay? And that is DPP-4 inhibitor, all right? So now we're gonna go to GLP-1, all right? And I know you're probably like, man, what are all these letters and numbers, okay? But it's a purpose to it. So GLP stands for glucose-like peptide, and they all end in tide, right? Peptide, tide, right? So you have extenide, and you have liraglutide, okay? And these are the trade names here, all right? Now, the action. How is this medication working? So it is working by increasing the insulin secretion and decreasing glucagon release. If you think about it, this actually sounds very similar to DPP-4, right? Because it's mimicking incretin, and incretin is doing what? Increasing the insulin and decreasing glucagon release, okay? So it pretty much kind of works in the same way, all right? So you're going to have adverse effects, which is pancreatitis. So this medication can cause pancreatitis, and pancreatitis is pretty much inflammation of the pancreas. And remember, there's so many things that goes on within the pancreas as far as insulin, you know, glucagon, the breaking down of foods. The pancreas plays so many roles, okay? So pancreatitis is a very big deal with this medication, okay? And the side effects is pretty much, you know, your typical side effects, which is going to be the GI disturbances, okay? And another thing with the GI disturbances, if I didn't say it before, the reason why you have the diarrhea, and the reason why you're going to have the diarrhea is pretty much, remember when those sugars are going into the colon, right? And you have the flatulence. Well, how does water travel, right? The least resistance, right? So if I have a high concentration of molecules and, you know, different things in one area, the water is going to flow to that area, All right, so if all of the sugars and molecules and substances are in the colon, where is the water going to go? It's going to go to the colon. And once the water goes to the colon, that is what's going to cause the diarrhea. So just in case if you guys wanted to know why diarrhea is one of the things that happens, that is the reason, because the science of osmosis, okay, and how water traps. So next we have human amylin analog, and pretty much what this is something that we naturally have in our bodies, right, that this drug is mimicking, okay. So the only drug that's in this class is called pramlintide, okay, and the mechanism of action, how this drug is working within the body, is that it is decreasing the glucose in the blood and decreasing the glucagon. And like I said before, if you decrease glucagon, you will definitely decrease the blood glucose, because the glucagon is used to raise the blood glucose. So if I decrease glucagon, then I'm going to decrease the blood glucose that's in the blood, okay? So this medication is mimicking something that our body naturally have and that is already doing within our bodies, okay? So this drug is just mimicking. Alright, so I know you guys probably saying, oh, Tashelle, you didn't go over all the contraindications for each and every single drug. You know, one thing I do want to let you guys know, if you think about it, the contraindications are going to make sense. And if you think about the medication and what the medication is doing and the side effects of the medication, you would then get what your contraindications are going to be. So remember when I was mentioning the carb blockers, right? You had the acarbose, right? And you had the fact that they work in the GI tract. Well, think about it. The ones who have GI problems or GI diseases or issues, right? They're not going to be able to take that medication because it's working in the GI tract, that they already have a weak GI system because they have a disease or they have some type of disruption of the normal process. So any irritable bowel disease, which I'll mention in another lecture, okay, and colic ulceration, all right, these are both GI problems. Of course, that medication is not going to be a good choice for them to use, okay? So that's how you know you're contraindicated. Sometimes you can look at the side effects and see, hey, if a person has this, you know, that's not going to work for them because it's ultimately going to cause the very thing that is going to damage their system, which they already have a problem with already. All right, those medications that cause the renal failure or liver failure, right? Remember the glitazones cause the liver failure. And then you have many medication that works on the kidneys, right? You had the metformin. Remember the metformin where you had to wait the 48 hours, you had to check the bunny creatinine levels, right? So if a person has renal failure, I may not give you metformin just because it's already going to damage that area and the area is already damaged as it is. So it's just going to cause more damage on top of damage, okay? And then cirrhosis, which I'll discuss at a later time, is also another complication of a liver disease, okay? So again, with the glitazones, I'm going to stay away from the glitazone because that is a medication that is ultimately can cause liver failure, and I already have a weak liver as it is, okay? And then pregnancy, most of the time pregnancy is always going to be a contraindication with certain medications. Now, with medications, they all have a category. And they can have a category A, B, C, D, all right? And of course, D is the worst, or one of the worst, okay? And they go into different categories. After C, it becomes borderline. And the category just pretty much talks about the safetiness of pregnancy, okay? So you just want to make sure you go over your categories to just make sure which medications are safe for pregnant women and which medications are not safe for pregnant women, okay? And you will find the risks based on category. So when you look at your medication, look at what category it's in. You have A, B, C, D, and I believe E. Not too sure. I'll go back and let you guys know. I'll put it in the description section once I look it up. But definitely after C, C becomes borderline, okay, with pregnancy. D, you definitely do not want to use for a pregnant woman, and anything higher than that, okay? But A, B is okay, C kind of borderline, and then D and anything else higher than that, you don't want to give to a pregnant woman, okay? So these are the contraindications. So when you're thinking about your contraindications, think about your adverse effects and your side effects, and think about, hey, if I don't have a strong system as it is, and these drugs are going to cause a beating on me, right? they're going to just destroy the organ that is already weakened as it is. So definitely those are going to be contraindications. So after going through this, as you can see, why diet and exercise is the #1 treatment, right? There's barely any side effects. The most side effect you'll get is hypoglycemic. I can deal with a hypoglycemic patient because all I know that I need to give this patient is sugar. All right? Okay. So now we're going to talk about insulin. All right? And I know when it comes to insulin, it can be very difficult just because it's a whole lot of stuff to remember. Different types of medication, different peak times, different duration times, right? And we can get confused, right? Like this onset and that onset. So as I was surfing the web, I came across a nurse. I think her name is Sarah. I can't remember her last name, so I'm sorry if I'm not citing you correctly. But I saw she did something like this. And I know this will help those of you guys who are mnemonics freaks or need mnemonics to help. And I found that this was very beneficial to kind of help remember insulin, okay? So I'm just going to go ahead and use it. And from there, I hope that this benefits you guys in understanding insulin a whole lot better, okay? So this came from a nurse named Sarah, and I thought she did a great job explaining it. And I said, why mess it up? Why even try to manipulate it? Just use the exact same thing because it works. So for those of you guys, this can help, okay? So we have insulin, all right, and we're gonna have it written straight down here. All right, now I'm gonna take my black marker and I'm gonna go ahead and go over the categories of insulin. So we have 4 different categories when it comes to insulin, right? And we have rapid insulin, we have short insulin, right? Then we have an intermittent insulin. So as you can see here, the U is in the middle, all right? And intermittent insulin is called Humulin, okay? So I'm gonna use that here, Humulin, all right? And then last but not least, we have long-acting insulin, okay? So these are the different categories. You have rapid, short, Humulin, and long insulin, all right? Now, I'm just gonna go over some of the medications, some of the insulin that are in that category. So for rapid, we know rapid happens very, very fast. Short happens fast, but not as fast as a rapid, okay? And then intermittent is like we said before, it's in the middle, all right? And then long is all day long, all right? So with rapid, we have Humalog, all right? And then we have Novolog. All right, so these are your rapids, Humalog, Novolog. And another website that I went to kind of help give you guys tips and remembering, he used the thing of a nurse going down a log, right? When she's on the hill, she's going down the log is gonna go really, really, really fast. So when you think of logs, okay? Your logs are your rapid, okay? Just in case if you mix it up with Humulin, right? Because sometimes that can happen. So Humalog, Novolog, log, a log going down a hill is going to happen very, very fast. Okay. Next thing is short insulin. Short insulin, we have what we call regular insulin. Okay, and regular insulin, I'm just gonna put it over here. Regular insulin is Humulin R and Novolin R. Okay, so with the R's, that's how you know it's short. So right under short, you have your regular. And as you know, your short insulin is the only insulin that is able to go IV. So only insulin that, only insulin can go IV. Okay? Which is your regular. Your regular. Now we have Humulin, all right? And Humulin is also known as NPH. So NPH, all right? And that is your, I'm just gonna put it here, Humulin N, and Novolin N. So as you can see, very similar, but these are the ones with N in them, okay? So NPH, all right, that's going to be your intermittent insulin, okay? And then last but not least, you have your long. And for long, okay, you have two in this category. You have Levemir and you have Lantus. All right, so Levemir and Lantus are your long insulin, okay? And this lasts all day long. So this is to help remember the categories. So those of you guys who, you know, like to go by mnemonics, this would be a great tool. And then also too, on your test, you can also write on your test or on the desk or anywhere you can write it, so that way you have an idea of the different categories. So when you see a question that's going to be talking about insulin, you already kind of have your categories mapped out. Okay, so as I was saying here, you want to be careful not to give insulin in just one repeated area, okay? And insulin can be given sub-Q and only IV if it's regular insulin, okay? So if you constantly put in the armpits, right? You put it in the, or the thighs, or you like to put it in the abdomen, whichever one of those three spots that you like to put it in, constantly over and over without rotating those areas, right? You would develop a thing called lipohypertrophy, and pretty much what that is it makes the skin tough, and it also creates lumps. So lumps and tough skin from the constant repeating of injection in that site, okay? It breaks apart that fatty area, okay? And sometimes you may have discoloration as well in those areas, and you can actually see the difference, or the blanching, or the lumps in those areas, okay? Another thing, insulin pumps, okay? So with insulin pumps, right, it's implanted into your abdomen, and these patients, they pretty much know how to manage their own insulin pump. So within the hospital, there's not much that we need to do as far as on our part with the insulin pumps. They manage their own insulin pump, okay? They make sure that they have their doses calculated to the way they needs to be calculated before each meal or after each meal, and they have to make sure that they bring their equipment to then replace it, because it comes in a little canister or so, and once it's empty, they need to, you know, they're responsible for changing those things, okay? And if they do not have, then of course, then we would step in the hospital, and then we would give them insulin. And with that, mentioning about insulin, as we administer insulin, insulin is only administered only in insulin syringes, okay? Because insulin is measured in units and not mLs. So, you know, you would need the syringe that labels on the syringe the different units, amount of units, rather than having mLs, because then you're not going to get the right one, and then you may give too much or too little insulin. So just make sure when you're administering insulin that you're grabbing the insulin syringe, okay? And you'll know because it comes with that sub-Q needle, all right? So that's one thing that I wanted to mention here, is the insulin pumps are pretty much an implantable thing that happens in the abdomen, and they're responsible for that. The insulin administration is only with insulin syringes, and again, you want to make sure that you're rotating the sites, okay? And the main common sites to get are the fatty areas, which is the armpits, right, the abdomen, and then you have your thighs, and you want to make sure you're rotating, okay? So you have different points. You have 6 different points, okay? Maybe even more in the stomach if you can kind of grab different areas here. But you want to make sure that when you're doing it in the abdomen, you look at your belly button as a marker, and you want to go 2 inches away from there, and you have this whole perimeter that you can work with, okay, with the abdomen. And then you just want to put it in those areas where you have the fat, okay? So now, some doctors may choose to use a sliding scale, okay? And you may say, what is a sliding scale? So a sliding scale is just pretty much a chart that has blood glucose, right? And they have the different levels of different blood glucose here, and then they tell you the amount of insulin that they want you to give per the level, okay? Now, Some patients, most of the time in the hospital, the doctors would use a sliding scale. Now they can have the protocol one that the hospital policy uses, or the doctor may deter from this and they may go over based on their own sliding scale. And sometimes that one, they may tell you, okay, call me each time you do the blood sugar and I'll tell you the level, okay? So you just want to be aware of which doctors you're working with and the orders that they want you to carry out, and just make sure that you're carrying out the appropriate way. And if you have any questions, you can always ask them. You can always ask the nurses or your charge nurse, okay? So with the sliding scale, the typical one, at least at my job, we have this one. And you can have different types of sliding scales. You can have a mild, you can have a moderate, and then you can have an aggressive sliding scale. This would probably be something that is, you know, a moderate, a sliding scale. Because then sometimes we have sliding scales where from 150 to 200, there's no coverage, okay? And then there's times from 200 to this, it's 2 units. So, you know, it depends on the type of sliding scale that the doctor orders. But just for an example base, right? Let's say I did the blood sugar and my blood sugar was 252, right? So I'm gonna look over here, which falls in this category here, right? And it says to give 6 units. So then I will go ahead and pull up 6 units in the syringe and I will administer it to the patient. Of course, I would then have to get it from the Pyxis, verify with another nurse, scan it to the patient medication, make sure it's the right medication, and then get an alcohol pad, clean the site, and then inject the medication, right? And you'll do the same thing, so on and so forth, with each blood glucose level that you get for each patient. And then sometimes here they may have a little note where if it's within 401 or greater than a certain number, right, to notify the MD. And when you notify the MD would then give you parameters or protocols that he wants you to follow, whether he wants the patient to be on an insulin drip. And an insulin drip, we talked about it before when we have a patient with DKA or HHNS, it's pretty much they're getting IV insulin continuously that is going to be titrated at different intervals each hour. And you're going to be checking the blood sugar each hour and administering based on your hospital protocol, okay? So this is the sliding scale. All right, so we're going to be talking about glucose elevating agents, and pretty much the definition is in the name, glucose elevating. And when would you give this medication? When the patient is experiencing hypoglycemia, right? So our very typical medication is glucagon, and I know we've heard glucagon several times already, so that should definitely be something that we are more familiar with and are aware of. So glucagon, we know in the body, it naturally stimulates the liver to then give up the glycogen that was stored, and then turn that glycogen back into glucose to then put it back into the bloodstream to increase the blood sugar. So that's exactly what's going on with the glucagon, the artificial glucagon, or, you know, the extra glucagon that you're going to be getting, okay? So the action is pretty much, it's raising the blood glucose by decreasing insulin release, and it's going to increase the breakdown of glycogen into the liver to release the glucose, okay? And then the indication, why are you going to be giving it, okay, is treatment of hypoglycemia, and it's absorbed fast within the body, okay, and then it's going to be excreted in the urine. So now we have D50W, okay? So D50W, you're probably saying, what is that? It's pretty much dextrose at 50% in water. In other words, this is your sugar water, and it's like almost like a syrup. And you can try to push it as fast as you can, but trust me, you can't push it fast just because it takes so much just to push it, because it's literally like syrup. So it won't even allow you to push it fast. But normally they'll say push fast, but again, it's like syrup, so you'll push and push and push and push, but eventually it's not going to go as fast as 1, 2, 3, okay? But you are going to push it, okay? Now, you can use a 25 ml or the 50 ml. It depends on the doctor's orders. So if the doctor tells you, okay, go ahead and give 25 mLs for blood sugar that's less than 60, then I want you to recheck it again within 15-30 minutes or so. And if it's still not at desired amount, then give the next 25. So some doctors can say that. Some doctors can say go ahead and give the whole 50, check again in 30 minutes, and let us know what the blood glucose is, okay? So these are the amounts that it can come in, and it's pretty much just dextrose at 50% in water, all right? And earlier, like I said, with the glucagon, when they give the glucagon, it's 1 milligram, okay? 1 milligram of the glucagon, it can either be given sub-Q or IM. IM is in the muscle, sub-Q is in the fat, okay? Now, over-the-counter and home interventions. So these are things that you can do outside of the hospital setting or outside from getting a prescription or anything like that. These are things that you can do on your own to kind of prevent hypoglycemia, okay? So we have 3 to 4 glucose tablets, and I've seen this many times when I'm going by the pharmacy, whether it's CVS or Walgreens. Right in that section, they have the glucose tablets that you can go ahead and pick up. They look like very fruity. You can see like they come in different colors, and you pretty much take 3 or 4 at a time, and it's pretty much like sugar tablets, okay? It's just pretty much sugar. And then you have 4 to 6 ounce fruit juice. The juice that they like to recommend is orange juice, just because it's very sweet and it can bring the blood sugar up really fast, okay? So 4 to 6 ounces of fruit juice, all right? You can also drink soda, but again, you know, soda is not really good for your health, okay? But the book does say you can use a regular soda, 4 to 6 ounces of that as well, all right? But try to stay away from soda, so I recommend orange juice, okay, or some type of fruit juice. The next thing you have is 6 to 10 hard candies, all right? And this can be anything that you like. As far as, you know, the Lifesavers, the hard Lifesavers candies, I love those. Or Jolly Ranchers, anything that's hard, okay, and that takes time for the sugar to be released. Because, again, those hard candies have what? More sugar. Why? Because the thing that makes it hard, all of that is sugar, caramelized sugar, okay? So hard candies, okay? And then you have 2 to 3 teaspoons, which we know, remember, teaspoons are what? 5 mLs each. So we have 2 to 3 teaspoons, okay? That's about 15 mLs, right? Give or take 10 to 15 mLs of sugar or honey, all right? So with the sugar, I know you probably saying, okay, how can we take that? Of course, you would mix it in water. So you would take either 10 or 15 mLs of water and then take some sugar and mix that in and then drink that, right? And then you have honey, which I prefer the honey just because it's easier. You can just take it and just take the spoonful just like that, okay? So these are the interventions for hypoglycemia. Okay, so when it comes to the blood glucose, right, you want to see if treatment is working, if it's effective, and if it's not, what are you going to do after? So when you have the blood glucose levels, you're going to retest them within 15 minutes. Once you recheck them, you're going to retreat if it is less than 70 to 75 of the blood glucose level, okay? So anything less than 70 to 75, you're going to retreat. Now, in the hospitals, it depends on what the doctors ordered. Like I said the scenario earlier, you know, give D50, 25 mLs, you know, check again in 15 minutes or check again in 30 minutes, because I know at least my hospital, we do it in 30 minutes. So again, this information is going to vary based on the different hospital that you go to and based on their policies, because each hospital have their own policy that they go by and that they follow, okay? So as long as it's within the hospital policy, you're going to recheck, all right? So that's the main thing. You treat, check, okay? So once you've checked, if you see that it's not within the range, you're going to do something else, okay? Whether it's that same intervention or something different, okay? And that's the concept that I want you guys to get from that, okay? So this will definitely differ based on hospital to hospital and what the doctors want, okay? Some may say give 50 one time, some may say give 25 of D50 and then give another 25 if the treatment is not working effectively, okay? Or they may say switch to glucagon. So it all depends, but follow the doctor's orders, all right? You can never go wrong with that. But stating the book, you retest in 15 minutes and you treat if it is less than 70 to 75. Now, if your symptoms last longer than 10 minutes after the initial intervention or treatment that you've done, you're going to go ahead and just retreat again without even checking, because sometimes it may not be possible to recheck. And then again, if they're having these symptoms, right, and remember the symptoms of hypoglycemia: sweaty, cool, and clammy, right? So what does this person need? They need candy or some type of sugar. So again, if they're still exhibiting those symptoms, then maybe the sugar has not raised enough, okay? And sometimes, you know, you'll check and you'll see that it's not where it needs to be. So then instead of just wasting time, you just go ahead and retreat them, okay? And then last but not least, once the signs and symptoms have resolved, right, after treatment, you want to give them a snack that's containing either protein and starch, or, you know, a combination of both. So examples of that, you have your milk, you have your crackers, you have your cheese. Another thing that NCLEX is adding to that is pretty much like a sandwich. They want something that has more substance that can kind of keep them leveled throughout the day. So sometimes you will see that they're saying whole grain bread with peanut butter sandwich, or a ham and cheese sandwich, something like that can give them more substance. Okay, so that's one thing I noticed when I was in nursing school, that NCLEX was starting to change their answers when it came to, it wasn't just no longer little simple snacks. It was more like a more solid snack that can kind of keep their blood sugar level throughout the day. So anything as far as whole grain bread, I know I saw that a lot, peanut butter sandwich or something like that, okay, are going to be things that you want to give them as a snack after you've done these interventions, okay? And then the only time you won't give them a snack is if the patient is planning to eat a regular meal, whether they're going to eat it within 30 minutes or 60 minutes, but it has to be within that window, and then you won't have to give them a snack because, again, their meal is going to consist of a larger portion where their body's able to get a lot more sugars from that, okay? And again, earlier, when I mentioned about the drugs, the medication that causes glucose elevating agents, those are given within the hospitals or with prescription, and those are what you would use in an emergency situation. Why? Because it works very, very fast, okay? If you're home, you have a diabetic, or you're a home health nurse or things like that, these are some interventions that you want to do first before you get to those measures of having to get into the medications, okay? So these are things that you do first: the drinking of the juice, and, you know, make sure you have the glucose tabs, okay? Especially if you're a diabetic yourself, you know. So again, these are home things that you can do at home. If it does not resolve or the symptoms last longer, then you want to kind of step it up and do emergency interventions, okay? Which is your glucagon 1 milligram, okay, and your D50, whether it's 25 mLs or 50 mLs, and then your dioxide, okay? And I hope that this video was very helpful. Again, remember to please subscribe, and if you have any comments, you know, don't be shy, comment in the comment section below. I'll try to put as much videos as I possibly can about nursing. Sometimes you may even have a request. I can go ahead and do those things as well. So again, I hope that this video was very helpful in understanding diabetic medications, and I can't wait for you guys to join on and share the videos.